with the cost.
That's correct.
Have you asked the administration, you're talking about currently it's a 7.2% growth, and you're talking about taking it down to what, 4?
It's 3.5 plus a 1% growth rate in population. So it's 3.5% cap in spending growth,
okay,
plus a 1% growth.
So you're talking about cutting costs by half, the cost growth.
That's correct.
Okay. Have you talked to the administration about whether they feel that's feasible?
We have. In the bipartisan, bicameral discussions, again, projections are projections, and we have to take them for what they are. So nothing is gospel. But because they are already engaged in pretty progressive payment innovations, pay for performance for everything from skilled nursing facilities to passport providers, this is the proposal is basically to build upon and expand upon those innovations that they're already looking into. It is a heavy lift, but it is one that we intend to do in conjunction with and in partnership with the administration. Now, I will say that I have not had a subsequent conversation with them within the last 6 weeks, but they are aware of these discussions, and they have participated in some of these bipartisan, bicameral discussions in past weeks.
And is it fair to say that most of that reduction in cost would come from utilization, efforts to limit utilization?
Not necessarily, no. This is about improving outcomes while increasing efficiencies. So, I mean, when you talk about utilization, what I want to make sure people understand is that utilization isn't about cutting access off and curtailing access to limit utilization. It's about making sure that the acuity level meets the service that is needed. Again, reducing ED utilization, shifting over to, the patient-centered medical homes, linking individuals up with primary care physicians, utilizing professionals at the height of their scope of their practice to make it more cost-effective, and penalizing and rewarding providers for delivering health outcomes. So again, if you are, for example, have a high rate of inpatient hospital-acquired infections, you're going to get a reduced rate if you're dual eligible, no different than Medicare. If you are a repeat offender at a skilled nursing facility that continues to send people into the inpatient hospital, you too are going to have a cost share in that burden, no different than the inpatient hospital facility. So this is about a shared responsibility between the providers and the patients at all levels of the continuum of care for Medicaid beneficiaries and for dual eligibles, those that are Medicare and Medicaid beneficiaries together.
You protect against cuts in eligibility. Do you protect against cuts in services themselves?
Yeah, the services can't be changed because of the federal law.
Even under optional services?
Here's the thing. Whatever we had in May of or March of 2010 is frozen in time. So that is frozen in time under the federal law.
At what point do you shift and say, we're not going to pursue a bill anymore, we're going to pursue some kind of a ballot issue? Or do you keep on a parallel track in terms of engaging advocates?
Well, and we have been engaging advocates, and I would say that is something that, we certainly reserve the right to do, and I can understand the frustration by the public because, but here's my issue. If we just say, okay, we're going to wash our hands of this and let this go to the ballot, we are abdicating our job as members of the General Assembly. We are here to act. We are not here to hedge and then basically say, okay, people, you make the decision, and then who writes that ballot language? Is it the hospitals? Is it the unions? Is it the Chamber of Commerce? And then we have no say. Is it in the Constitution? Is it in the Ohio Revised Code? I don't believe that there is a necessity to complicate matters. But if that's the only option, if the General Assembly continues to lack the courage to do what's right, then we do have to consider any and all alternatives.